This all of us must be aware. There was a circulating WhatsApp message, and you can see posters like this in the streets that asking people to check D-dimer if they have COVID or they have taken a vaccination, and if it is positive, you are at higher risk of developing. So from that paper itself, we can be sure that D-dimer is a inappropriately used test in most of the cases. So there are 2-3 scenarios we usually come in our day-to-day practice. I will highlight one or two of them. This is a 70-year-old female with a post-operated A1 fracture of femur, history of hypertension, diabetes, and dyslipidemia. Her pre-procedure cardiac evaluation was normal. She develops acute dyspnea, and a panel of investigations including tropi, D-dimer, BNP is sent. And this is another male patient admitted with pneumonia. His risk factors are diabetes and hypertension. He has also worsening of dyspnea during his hospital course. His CRP, TC is increasing. He is febrile. And there are also a set of investigations for worsening of dyspnea, that is D-dimer, tropi, and BNP all are sent. And another OPD patient, 45-year-old male, family history of CAD and sudden cardiac death. There is no risk factors for him. He comes for a total body checkup, and D-dimer tested by him outside is positive. So in these patients, what we are going to do with the positive D-dimer? So just to overlook what is the D-dimer, we all know that in the presence of thrombin, after activation of coagulation pathway, both intrinsic and extrinsic, the fibrinogen is converted to fibrin monomers, which gets polymerized fibrin polymers. And in the presence of factor 13, it is stabilized with the cross-linking polymers. And once this mesh is formed, this acts as a base for further clot formation. So as we know, once clot formation is there, fibrinolysis also occurs in the body. And in the presence of plasmin, these polymers are degraded. And one of the end product is D-dimer, and you have fibrin degradation products also. So this is a diagrammatic representation of that. So coming to D-dimer, their half-life is approximately 8 hours, and they become detectable in the blood after 2 hours of a thrombus formation. Normal values are less than 500, and in elderly patient you can use a rough calculation like age into 100, not into by 10 factor is there. So if an 80-year-old person, you can calculate it as 800 microgram per liter, not as 500. And in pregnancies, especially in final stages of pregnancy, it can go up to 2500 microgram per liter. So can D-dimer be elevated in a normal person? So we always know that there is a homeostasis, that is there is a thrombotic system and an antithrombotic system active in all of us. And the physiological condition, approximately daily 2 to 3% of fibrinogen is converted to fibrin, which is degraded by fibrinolytic system. So definitely all normal persons will have a mildly a detectable level of D-dimer in their blood. And it increases physiologically with age, pregnancy, puerperium, and it may be higher in African Americans and cancer patients. These are the conditions where it can be elevated in a pathological state, that is venous and arterial thrombosis, infections, DAC, neoplasms, trauma, liver and renal diseases. All CKD and CLD patients can have elevated D-dimer. Post-fibrinolytic therapy, ACS, CVA, head injuries, bleeding, and obstetric complications including preeclampsia, eclampsia, all those things can have elevated D-dimers. So we have usually 4 kinds of tests available: ELISA, immunolinked fluorescent assays, lattice enhanced immunoturbidimetric assays, and point of care. So ELISA method and the ELFA is considered as most sensitive methods, which are around 94 to 96% sensitivity. Because of the high sensitivity, their specificity goes down. And what are the factors that can affect while testing a D-dimer? If the clot burden is high, the D-dimer values will be very high. And timing of measurement, when you are doing it in acute setting, you will get a high value of D-dimer. And if you test it before initiation of treatment, the values will be high. So D-dimer levels falls with increasing duration of the venous thromboembolic symptoms, and D-dimer levels also rapidly fall after initiation of therapy. So it is best done when the patient presents with an acute setting, has a large clot, and before initiation of therapy, the value of D-dimer is high. We have to remember that patients with genetically low levels of factor 13 or those who have homozygous mutations leading to absent factor 13, even with high large clot burden, D-dimer may be negative. D-dimer will be negative. So when is a D-dimer measurement useful? You are in a clinical situation where the pre-test probability of DVT and pulmonary embolism is low or intermediate, and you want to rule out DVT pulmonary embolism rather than rule in, and you want to avoid an unnecessary imaging in a patient whom you suspect to have a low suspicion of DVT pulmonary embolism. These are the situations where D-dimer is useful. So coming to special situations in pregnancy, D-dimer physiologically itself increases, and in the second trimester it can go up to 1500, and in the third trimester up to 2500, and usually it comes back to normal after 6 weeks of postpartum. But in the pregnancy setting, if the D-dimer is negative, it has a 100% negative predictive value. So COVID, we all know, it determines the significance of severity and mortality. It is signified by high D-dimer, but elevated D-dimer is most likely due to acute lung injury and thromboembolic phenomena. So any DVT or pulmonary embolism in COVID also, it is treated in the same way. We give anticoagulation for 3 months or 6 months accordingly. And the severe COVID, 10 to 15% have elevated D-dimers even on follow-up without overt thrombosis. And there is no data to support use of prolonged OAC in patients who are having mildly elevated D-dimer on follow-up. Vaccination can lead to rare episodes of complications and elevated D-dimers, but the values are very low, and no medical bodies advise to do routine D-dimer in asymptomatic COVID patients for follow-up. Cancer patients have a separate set. They have a 7-fold increased risk of developing venous thrombosis compared to general population, and the Wells decision criteria for D-dimer testing is less effective for making a diagnosis in patient with cancer and suspected VT compared to those without cancer. Most of the active cancer patients are not having a low pre-test probability of DVT and pulmonary. That is why the usage of D-dimer in cancer patients is not very useful. So when you suspect a patient with a DVT pulmonary embolism, you have a clinical evaluation. You use the Wells criteria or the revised Geneva criteria and stratify into low, moderate, and high risk. And if the pretest probability is low, you go for a D-dimer. If it is negative, you rule out thromboembolism. If it is positive, you go for imaging and confirm the diagnosis. And if imaging comes negative, then also it is excluded. Moderate and high, you directly go for diagnostic imaging rather than D-dimer. There is no point in using D-dimer in moderate or high risk patients. So why it is not useful? If the patient is having moderate or high likelihood of venous thromboembolism, D-dimer should be omitted, because D-dimer result is unhelpful when the pretest probability is likely because of these 3 reasons. The result is unlikely to be negative even if venous thromboembolism is not present, and positive result still requires a confirmatory test like ultrasound or CT pulmonary angiogram, and the uncertainty that D-dimer testing can be safely exclude a venous thromboembolism in this high risk patient. So even if you get a negative result, you may not exclude venous thromboembolism in a high risk patient. The same way, even if it is positive, you have to go for the imaging. So in high risk patients, better to go with imaging. So another situation is after 3 months of OAC for a patient of unprovoked DVT, they have high chance of recurrence. You do a D-dimer test, it is positive. These patients are at higher risk of developing thrombosis in the future, up to 30% in 5 years. But still no medical body represents the routine usage of OAC after 3 to 6 months if the D-dimer value is found to be positive. So there is a Vienna prediction score model which uses...
Hariharan, sorry to interrupt.
Yes.
Can we come to...
Yes, sir. Finishing, sir. This is the last slide. So D-dimer test is not a test to predict, diagnose MI or stroke risk, and it's a test to rule out DVT or pulmonary embolism in a population with low risk of DVT and pulmonary embolism in the pre-test probability assessment. Thank you.